I'm here, Dr. Chandrashekhar. I'm a medical teacher and also teacher for spoken English. I also conduct classes for those who are aspiring to become medical professional and those who are trying to face the entrance exams. I'm working as an assistant professor, researcher, and assistant clinical research coordinator in Department of Pharmacology, AG Institute of Medical Sciences and Research Center, placed in Mangalore. I have basic degree in bachelor's, that is chemistry, botany, zoology from JSS College, Mysore. I completed my professional course in medical of Indian System of Medicine in Mysore. I completed my postgraduate in medical pharmacology from Kasturba Medical College, Manipal University, Bangalore. I have received an award as a best outgoing postgraduate in pharmacology from Kasturba Medical College, 2009. I have completed my Doctor of Philosophy in medical pharmacology from Ennepoy University, Bangalore. I've been teaching students from quite a long time from now in terms of pharmacology, spoken English, and also for crash courses in CET. I'm also working as member of scientific committee in AJMS Bangalore, as a biological scientist in IIEC under the Government of India, and I have my own journal that is called as International Journal of Comprehensive and Advanced Pharmacology, where I'm working as editor-in-chief. I have more than 75 publications in national and international journals, which includes research and review articles, which have a high impact factor, and that is related to neuropharmacology and ethnopharmacology. I'm also serving as a reviewer and member of many journals in the editorial board team. Currently, I have authored more than 15 books in medical pharmacology, and I'm here to help you all in your learning process, which makes the concepts very simple and easy with all the relevant example for your future prospects. Students, today we learn pharmacology with Dr. Chandrashekhar, that is myself. Now, the topic we are going to discuss today is peripherally acting skeletal muscle relaxant. Now, why skeletal muscle relaxants needed clinically, and what is its history? Now, how we classify it, and what's the role of acetylcholine as a neurotransmitter at neuromuscular junction, and what's the physiology of skeletal muscle contraction we were studying in the earlier years, and what really these peripheral acting skeletal muscle relaxants do. Now, if you move on to the purpose of using skeletal muscle relaxants clinically is, it can be used in conjugation with general anesthetics to facilitate intubation of the trachea, because whenever you pass the endoscopic instrument, there's always a constriction of the muscle, so we have to relax it, otherwise it may produce some problem. And also to facilitate mechanical ventilation in terms of emergency condition, we need to relax the skeletal muscle. And also to optimize the surgical working conditions, because whenever you want to do some surgery, there's always a reflex contraction of the skeletal muscle. You need to relax before you perform any operations. That's why we use this skeletal muscle relaxants. Now, when we broadly classify the skeletal muscle relaxants, we can classify as centrally acting skeletal muscle relaxants and peripherally acting skeletal muscle relaxants. The central acting one are diazepam and other drugs, like we have benzodiazepine. Now we have methocarbamol, chlorzoxazone, tizanidine, baclofen, and gabapentin. They all are going to reduce the reflexes from the spinal cord and reduce the contraction of the skeletal muscle. That means they cause relaxation of the skeletal muscle by acting through central mechanism. When we move on to peripheral acting, that is today's topic, we have two classification under this. One is drugs acting at neuromuscular junction, and some drugs directly act on the skeletal muscle. That's why we have only one drug in there called Acetylcholine. When we move on to drugs acting at neuromuscular junction, it can be depolarizing NM blocker or blockers. We have two drugs under this, succinylcholine and decamethonium. We have non-depolarizing blockers, also called as competitive blockers. We have DTC, that's D-tuberculin, pancuronium, doxycurium, pepacuronium. That can be classified as long-acting because they are longer acting compared to other drugs. Vecuronium and atracurium, they are intermittent acting, including the rocuronium. And we are the shortest acting skeletal muscle relaxant, that is nevacurium. Another drug which is having a little less important, it's called botulinum toxin. That's only toxicologically important, not the clinically important. Now, when we move on to the history of skeletal muscle relaxants, the people who used to live in Central and South America used to have one game hunting, or they used to have some kind of poison where they used to smear it on the tip of the arrow and hit the animal. The animal hit by this arrow used to run a quite a distance and fall down, but they used to not die. They used to get paralyzed. These people used to bring the animal flesh and they used to cook and eat, but they used to not get any effect of the poison. So a scientist observed this. Later, he worked on this chemical and he found out that these are nothing but the poison substance. What they used to use was called as curare. It's a source they used to obtain from a plant called as Chondrodendron tomentosum and Strychnos toxifera. But when they consume this, it does not get absorbed from the GI tract. But when you inject it, it used to cause skeletal muscle relaxation. And when he tried to find out what's the reason for this and what's the cause for this, he found out that it is acting at the neuromuscular junction, and this should be given parenterally, not orally, parenterally, away from the GI tract. Later, it was named as tuberculin because these people who used to live in this forest, they used to fill this poison in a tube, bamboo tubes, and they used to just dip the tip of the arrow in this poison and hit the animal. Then they named it as tuberculin because of packing in the hollow bamboo tubes. Now you know the parasympathetic nervous system, where acetylcholine is a major neurohumoral transmitter which acts as the autonomic, somatic, and central system. And they release at all preganglionic sites, both sympathetic and parasympathetic, especially at the neuromuscular junction in the skeletal muscle. And also they are going to produce in CNS, in the sites, we have cortex basal ganglia, spinal cord, and others. So that's why acetylcholine is released at neuroeffector junction in the parasympathetic stimulation, and on the contrary, the sympathetic stimulation will cause release of noradrenaline at the neuroeffector junction to exert the biological effects. You can see here preganglion fibers, acetylcholine. The postganglion also acetylcholine for parasympathetic system, and there is a muscular receptor. There's a pharmacological action. For sympathetic also, all preganglionic are acetylcholine, but postganglionic is norepinephrine. So this is the neuromuscular junction. The acetylcholine gets released based on stimulation, and they act on the post-junction receptor. Either it may be nicotinic or muscarinic. When we talk about nicotinic, it is NM receptor. NM receptor present at the neuromuscular junction. So if you see the physiology on arrival the motor nerve impulse, there is a release of acetylcholine, binds with the NM receptors at the neuromuscular junction. It causes depolarization and development of the end plate potential at motor end plate, mainly to influx of sodium. It leads to muscle action potential followed by contraction of skeletal muscle, and acetylcholine later on get rapidly inactivated by cholinesterase, leading to repolarization. The muscle is ready for the fresh nerve impulse. And as I told, the peripheral action skeletal muscle relaxation, we have two types, non-depolarizing and the depolarizing. The non-depolarizing the one, they interfere with the action of acetylcholine by blocking the NM receptor. They block the NM receptor here. They block the NM receptor. That's why they're called as non-depolarizing, where acetylcholine cannot act on this, and the whole pathway gets blocked. So that's why they also called as competitive blockers, antagonists. We can divide further these drugs as short-acting, intermediate, and long-acting, as I already told in the classification. Whereas if you come to the depolarizing, they look like acetylcholine. The drug is acetylcholine. They initially cause depolarization, and as they got persistent depolarization, the muscle gets relaxed later. That's why they're called as depolarizing NM blocker. So today we are going to discuss only about the non-depolarizing NM blocker. That is this one. That is your curare-like group of drugs. So as I told, these non-depolarizing SMR, skeletal muscle relaxants, have affinity but no intrinsic activity for NM receptor. They are quaternary and compounds contain cationic head that act only on the closed sodium channels. Thus, we have no action on already open sodium channels. So, because of there is no end plate potential generation in the nerve ending, and muscle action potential decreases. They also block the pre-junctional acetylcholine receptors on the motor nerve ending. That's why it is also called as fade phenomenon. Fade phenomenon. This you can see non-depolarizing NM blocker acting on here, and it closes the influx of the sodium channel. So the most commonly used drug was once upon a time D-tibocurine, 1 to 2 hours duration of action, but they had an adverse effects called histamine releases. They used to cause bronchospasm and hypotension, and also they block autonomic ganglia, leading hypotension. Because of the partial blockade of ganglia at NM receptor type, they result in fall in BP and tachycardia. So that is under the autonomic ganglia. They also known to cause histamine release. That's why they cause hypotension. Bronchospasm, especially very fatal in case of those who are having bronchial asthma, and because of increasing the secretion of bronchial glands. As we already told, in the cardiac system, they cause fall in BP, maybe due to ganglion blockade, histamine release, and they, especially the acetylcholine, used to cause cardiac arrhythmia. That's not today's topic. So, and GAT, it may also cause cardiac arrest. The use, as I already told in the first slide, that these are the main drugs used in case of to facilitate the intubation of trachea, for facilitating mechanical ventilation, to optimize the surgical working conditions, and also sometimes it is used to reverse the effect of neostigmine. That is the later topic. As we already know about the pharmacological action, it used to cause hypotension, tachycardia, and also lead to allergic reaction by causing histamine release, leading to rashes, itching, and urticaria. These are a part of adverse effects of the NM blocker, especially the non-depolarizing type, and especially it's for the depolarizing. That's why we are using nowadays the later drugs like pancuronium, mercuronium, mivacurium, and etc. So that's all today's class about peripheral acting skeletal muscle relaxants or NM blocker. Students, just now you have heard about my teaching on skeletal muscle relaxants, and I hope it was very brief and it was very informative. At some people who are hearing for the first time may have some doubts here and there, and especially after you go and read from your book, you may have lots of queries. So if you want further information about that, any clarification doubts, you can always contact me through UrbanPro, and their team are very good and they are going to help you. I'm always at your service. Thank you.